I appreciate this opportunity to talk about ADHD, which is basically my favorite topic to talk about in the whole world. This presentation was put together by myself and Kim, who just graduated from undergrad here and is pre-med, and a colleague of mine, a second-year Palestinian psychiatry resident, Dr. Nizar, who's based in Bethlehem. In terms of disclosures, I've received a couple of peer-reviewed papers from Ironshore Pharmaceuticals, and I will likely seek grant funding from them to investigate questions relating to the adherence of ADHD medicines in the evening. The other doctors or colleagues have no conflicts of interest. So about myself, so I'm an ADHD specialist. I have an academic interest in women and girls with ADHD and feminist and philosophical critiques of our existing diagnostic systems. My clinical practice is focused largely on mothers with ADHD and also families where multiple family members have ADHD. And I have now a 20-year commitment as of 2024 to being supportive and helpful and solidarity in whatever ways I can in the Palestinian health sector. And it's a pleasure to have a longtime mentor of mine, Dr. Ray Mitchell here, who I've been fortunate to have a number of mentors, but possibly when the going was quite rough, Dr. Mitchell's mentorship was the single thing that kept me working in this area, even though many of the individual projects and attempts that we've made to make improvements have not reaped the sustained rewards that we might have hoped. So thank you, Dr. Mitchell, for your generosity of spirit and for being with me many years along the way. My parents are also here, and so I'll thank them for raising me and being supportive. Okay, so today here are our learning objectives. The first one that I'll talk about is understanding ADHD from three different, somewhat, but not entirely overlapping perspectives. One of them is the perspective of the Diagnostic and Statistical Manual, the DSM, which is what we use here in the US and use in some other parts of the world to make psychiatric diagnoses. A second perspective is that in terms of thinking about executive functions, and a third is a gender equity perspective. And I also want to note that I've slated the presentation to be about 25 minutes, which means if there are questions as we go, I welcome those. There also should be time at the end. All of the research on adult learning tells us that if this is a one-way didactic, it will be less of a good learning experience than if we're in conversation. So what is ADHD? ADHD is a neurodevelopmental, highly heritable, and frequently lifelong condition. It's characterized by self-regulation difficulties. The DSM recognizes the first two here, problems with the regulation of attention and problems with the regulation of motor hyperactivity and behavioral impulsivity. Depending on the sample and the research approach, a large minority or a reasonable majority of people with ADHD also have significant challenges with emotion regulation, though that's not included in our current diagnostic criteria. ADHD is a highly morbid condition, and it's associated with an early mortality about 10 years on average. That's something that perhaps not everyone knows. And when folks are thinking about the risks of stimulant medicine and the risks of treatment and the challenges of getting controlled to substances to patients that need them, it's important to note that non-treatment is associated with very substantial morbidity and mortality, and that we always have to be balancing the risks of intervention with the risks of non-intervention. ADHD is highly heritable. This is a slide showing that ADHD is a ton more heritable than breast cancer or asthma, more heritable than schizophrenia, and just slightly less than height. That's an important thing to note, because if you're treating someone with ADHD, it's likely that they have another first-degree family member that has ADHD. And much of my practice is organized around helping 2 or 3 family members simultaneously, often a mom with ADHD and 1 or 2 or 3 kids, since mothers on average play a quite central role in families in our society. And if they have difficulty organizing and planning, they tend to suffer tremendously, and then so do the kids. So a family-based approach tends to work the best. ADHD is typically a lifelong condition, unlike insurance companies, which still require prior authorizations for every stimulant once you turn 18. We've known for multiple decades that most people with ADHD symptoms in childhood continue to have symptoms in adulthood. There are a lot of different studies, and the range is pretty great in terms of the estimated prevalence with regard to continuity of ADHD from childhood. We can say in the pediatric population, based on the DSM criteria, about 10% of kids have ADHD. To meet full criteria, it might be 5% of adults, but if you're a little bit more lenient and you say, did you have ADHD as a kid, and are you still like significantly impaired, but maybe you only have 4 of 9 rather than 5 of 9 within a particular criterion set, then you're looking at about 80% of people who had ADHD as a kid still have burdensome ADHD as an adult. And so the diagnosis in abbreviated form is a problem with inattention or hyperactivity impulsivity. This is the DSM diagnosis that causes problems. We need some symptoms present before the age of 12. And the symptoms need to be present in 2 or more settings. It's important to note you don't need reports from 2 or more settings. You don't need, if it's a kid, a teacher, and a parent report. And if it's an adult, you don't need to, though it's good to have a report from a friend or a partner or the adult of your, the parent of your adult patient. It's good to get collateral information, but it's not necessary for the diagnosis. And then this is for folks 17 on up. You need 5, not 6 of these criteria to be met for an inattention diagnosis. I'm not going to read them over here. They're readily available to you. But as you look at these, you will see that there is a pediatric bias in these criteria, though it got improved a little bit in the 2013 revision of our diagnostic manual. Some of the things that you'll see here, and even more so for the hyperactivity and impulsivity criteria, you see that some of these are not things that adults do, like running about or climbing. If an adult's doing a lot of that, you'd be more concerned about a manic episode than you would be about ADHD in an adult. So then they have this note, which is now 11 years old, right? But still relatively new in the world of ADHD. And adolescents or adults, instead of needing to observe someone running or climbing about, it may be limited to feelings of restlessness. But you can see here that the core criterion is still rooted in a pediatric view of ADHD, which makes it harder sometimes to accurately diagnose adults. A second perspective that we'll touch on is the executive function definition or conceptualization of ADHD. And in this approach, we see ADHD as a challenge with the brain's self-management system, or you could say self-regulation system. And this is across multiple domains. So you can see 6 domains listed here, right? People have difficulty starting tasks, sticking with tasks, completing tasks, difficulty with focus. There are motivational deficits, right? And so a pejorative term that ought not be used because it's unkind and it's not scientific is people are being lazy. Conceptualization of lazy, which also has some racist roots, is highly problematic, is that someone's like not trying despite the fact that they could. But with ADHD, although the neurobiology is not completely worked out, there are differences in dopamine signaling, and it's highly genetic. And so these fundamental problems with motivation and exerting effort, but unlike you might be thinking about it, this motivation issue is not entirely or sometimes very much under a patient's control. As I noted, there's an emotion regulation element to ADHD for many people. And so beyond the DSM, there should be a colon beyond the DSM colon, emotion regulation. But as I mentioned, at least 50% of people with ADHD have significant difficulties with emotion regulation. So if someone comes in, they had an ADHD diagnosis in childhood, or you get a careful history from an adult patient, and you see that they had some symptoms in childhood, maybe for a variety of reasons, they weren't identified as having ADHD. And they're having trouble with 0 to 60 emotional response or coming back down from an intense emotional response after they've gone up. So that could be a symptom of an anxiety disorder or depressive disorder, something else. But if all the symptoms you're hearing about could fit into an ADHD construct, then it would be more appropriate to consider that emotion regulation to be an ADHD problem than a problem arising out of a mood or anxiety disorder. This slide is really important. ADHD is a clinical diagnosis, and it's good to get multiple informants regardless of the age of your patient. Something that confuses our junior residents, so it certainly could be a source of confusion for non-psychiatrists, is that neuropsychological testing is neither necessary nor sufficient to make an ADHD diagnosis. There is no single neuropsychological test that's sensitive or specific for ADHD. And that's because when you're looking at some specific skill in a rarefied neuropsychological assessment environment where you have a child sitting, you have one adult looking at them, or it could be an adult for that matter, and they're doing some small task, it just doesn't generalize very well to the complex activities you have to do as like a human being in modern society. So psychological testing can be helpful for a variety of reasons, but it shouldn't keep you from making an ADHD diagnosis if a patient meets criteria and you feel like it's appropriate. The WHO ASRS self-report scale is free. It's one that I typically use with my adult patients. It doesn't line up perfectly with the DSM criteria, so you need to be familiar with the DSM criteria, but it's a better list for adults with ADHD. So you use both, and as you get practice with both, you find ways to combine them. The differential diagnosis for ADHD is any problem that impairs brain function, right? ADHD manifests in a variety of different ways, and so any condition that impacts the brain could produce ADHD symptoms. We often think in terms of a psychiatric differential diagnosis of mood and anxiety disorders and PTSD, since they're common in the population. Learning disorders aren't going to trick you very much in adults, but certainly in kids. If someone has a significant challenge with reading, known as a reading disorder or dyslexia, they may have trouble focusing on reading. They may have comorbid ADHD. They're actually likely to, but at times, the best conceptualization is really that they're having learning difficulties, and it's very hard to focus on something when you don't understand it. About 40% of folks who are autistic have ADHD. It could also be the case that you could be autistic or have ADHD and not have the other. So you need to be aware of that. That's an important piece of the differential diagnosis. Any substance use disorder is going to impact attention, and any sleep problem is going to impact attention. And often managing sleep is the most important thing I do with folks other than prescribing medications. So ADHD leads to various other comorbidities, and this is one model, not entirely mine. I think I borrowed this from Thomas Brown and Dr. Stewart, who was in faculty here, but I've expanded upon it. And so the idea is that folks who have ADHD are chronically misunderstood. They're called lazy, or the environment around me, that word's never used, they feel like they're lazy and a bad person. They get all this negative feedback. And then filtered through their personality, developmental and gendered expectations, culture, racism, and other forms of bias and misunderstanding, they may develop what we call more internalizing problems, depression, anxiety, shame, emotion dysregulation issues, or they may develop externalizing problems, problems for others in the environment, oppositional defiant disorder in kids, maladaptive personality traits. Personality traits exist along a continuum. So saying personality disorder would be more narrow than we should be. And also it's more pejorative. So I'm just saying maladaptive personality traits. And then also criminal justice system involvement often flows out. And so someone who has a propensity to blame themselves for problems is more likely to be depressed or anxious. And someone who has a natural propensity to blame others more for the problems is more likely to develop these externalizing problems. Many people develop problems in both categories. Now thinking about the problems with under-identification of females. So this is my area of main academic interest. You can see in this chart on the x-axis is age at diagnosis, and on the y-axis is number of patients. This is a big study, a Swedish population registry study. And what you can see is that the males in lighter gray get diagnosed at a younger age. And that there's, in terms of when folks get diagnosed, that males get diagnosed about 4 years younger. You also see that once females or women, I mean, adults, and they can self-advocate and they can self-present, the rates of diagnosis, first-time diagnosis for males and females in adulthood, it's like exactly the same. So what we see here and how we understand this is that males, on average, big differences, and there's a problem with discussing this in a gender binary way, but just at first pass, males are more disruptive, cause problems in the environment. Teachers and parents bring a child, adolescent, to the clinic and say, we're having problems managing this kid, teaching this kid in the classroom, et cetera. And then females have more internalizing issues, and so there's this bigger threshold for them to actually access treatment. This is a poster. So if you get the slides, which hopefully can be presented, you can actually read this poster, but you're only supposed to see the title right now. But this is a poster I presented just 2 weekends ago at our national ADHD conference. And my thesis is that the concept gender equitable can and should be a validator for ADHD. When we think about the ADHD diagnostic construct, there are 2 biases. I mentioned the kind of child bias. When ADHD was conceptualized in the 30s, 40s, 50s, 60s, and 70s, the samples were almost entirely or entirely children, and their males were massively oversampled. And so when people sat down to write initial criteria and then operationalize the criteria, what was most commonly observed in young, mostly white boys was what made its way into our DSM diagnostic criteria. And so it would be expected that these criteria would perform the best for male boys who are similar to those kids who were observed and on whom the diagnosis was initially conceptualized. And it would perform the worst for adult females. And there's a number of reasons, I won't get into all of them here, a number of reasons to think that's the case based on reviews of epidemiology and the literature. What I can say is that there is, I think, universal consensus among all of the experts, women with ADHD that I've talked to, that there is a gender bias in the ADHD construct so that it doesn't perform as well for females as it does for males. And so before you get too literal about the DSM, it's an important thing to know that there is a limitation there. A more gender-sensitive assessment of ADHD involves looking for subtle and attentive presentations. Girls with average to above average IQs often can be academically successful enough due to working harder than their peers. A history of a girl who wasn't identified in childhood might be, I did like twice as much homework as everyone else, and I got like B's. And some people said, I don't think you're performing up to your potential. I think there's something wrong here. But no one ever really thought to look into it more than that because this girl was not causing disruption in the classroom. And due to gender norms and a higher expectation for conforming to social norms, more girls than boys, though this can happen across all genders, may mask or camouflage their symptoms. Difficulties that can emerge include social difficulties arising from interrupting, hyperverbal speech, emotion regulation challenges. Through development, there's a slightly higher standard for social skillfulness among girls than boys, and so girls are more likely to get punished socially for suboptimal social skills. And then challenges emerge during academic and life transitions. Often 6th grade, there's more long-term assignments, 9th grade, even more, college work, partnering, and then parenting. Each new level requires someone to juggle more things at a time. And sometimes people can be very skillful at doing one thing at a time, and they hyper-focus or zoom in on that one thing. But once it comes to juggling multiple life responsibilities, everything falls apart. And people often articulate a sense of overwhelm that it increases maybe more than linearly, as I said, when there is more responsibility. And I distinguish, for communication purposes, between ADHD overwhelm, which is there are more things that I can keep track of in my working memory and with my skills for writing things down, and I never really feel like I know what I'm responsible for. And I'm never confident that I'm going to get everything done, or rather, I'm pretty sure I'm going to drop balls. And that could also sound like generalized anxiety. But if you hear their life story and they're always running late and they're always getting parking tickets and they're always losing their keys, right? And they say, I'm always anxious. I mean, maybe they do have generalized anxiety or another anxiety disorder, but initial conceptualization would be anybody would be anxious if they were consistently unreliable for themselves and others. And so you have to first be thinking, is there an executive function or ADHD related challenge? A little bit about the biology and about an inadequacy in a diagnosis that doesn't consider hormonal fluctuations over the course of a month or a lifetime. We know estradiol is really important for the synthesis, release, and reuptake of dopamine. Dopamine is the most important neurochemical when we think about ADHD, though any syndrome is a complex process using all of the neurotransmitters that there are, right? But we know that, like, in a very simple model, a dopamine deficit is associated with ADHD symptoms. And so without taking into account fluctuations in estradiol, it gets even more complicated when you look at progesterone, more complicated because, of course, there's inadequate research on how these fluctuations actually affect folks that have menses. And so we really don't have good literature to support exactly what we should do, but you need to be aware this matters, right? And then there is a perimenopausal or menopausal onset of ADHD symptoms in a relatively small percentage of the population, like a full ADHD syndrome, with symptoms emerging in a larger percentage, often best treated with estrogen replacement, not with ADHD medicines, though frequently, if you really want to optimize, you're thinking about both. And then on to the next slide. So dopamine modulates cognitive function in inverted U. So this is what makes it even more complicated and requires thinking not just about like the last 6 months, but also like where was your menses and where are you seeing these problems. There's research that people who have a baseline high dopamine state, when their estrogen levels get high, they're pushed to the right side of this inverted U, where they're too aroused. And they start to have repetitive or perseverative behaviors. They have, as it's noted here, impaired working memory, weak top-down control, and extreme dissociation, psychosis, et cetera. That's not usually what we're talking about, but a lower level of function because there's actually too much dopamine action. For most people with ADHD, we're talking about too little dopamine action, right? And when there's none, you're just asleep, right? And you get a little bit more and you're awake, but your brain's not really booted up. Many people with ADHD have delayed sleep phase, so they do pretty well if they could wake up at 10 and go to bed at 2 a.m., but society usually doesn't allow that. So they're like physically awake, but their brain's not really booted up. They're in a dopamine deficit state. And so it's important to be aware that too little dopamine is where we're usually starting with ADHD folks, but too much dopamine is also a problem. And you need to be thinking about how estrogen levels, even though it's not the whole story, fluctuate over the course of a month in someone who's menstruating. And so you can ask questions like, does your capacity to regulate or manage your attention fluctuate from week to week, right? Do you have mood symptoms, anxiety symptoms that fluctuate with your menses or monthly cycle? People with PMDD, in my clinical experience, actually sure that I know the literature on this, are more likely to have fluctuations in their attention symptoms if they also have ADHD associated with their premenstrual dysphoric disorder. One more challenge in diagnosis, and this is rarely discussed, and I don't really know why, other than it's just an unhappy complexity. But ADHD symptoms are distributed nearly normally in the population. So in the same way, systolic blood pressure is distributed nearly normally with maybe a bit of a rightward skew in the population, so are ADHD symptoms. And so if I just said, in your clinical judgment, who's hypertensive? I don't know if you know where to start. You need like JNC guidelines or something, and they tell you who's hypertensive, and it actually changes as a function of the science and as a function of how safe our antihypertensives are. If we get safe antihypertensives and a certain number, I'm not sure I'm up to date on the guidelines, but let's say 130, which is previously considered okay for a population, is now seen as involving a 50% increased risk of stroke and a heart attack. And we got really great antihypertensives that somehow don't make the blood pressure get too low. We're going to define down hypertension because the harms associated with intervention are going to be quite low, and we're going to manage that risk, right? So there's no like God's eye standard for what hypertension is. We decide as communities of practitioners based on the evidence we have. ADHD is like that too. Now, you can't just go throw out our guidelines. But when you look at these ADHD symptom scores, the rightward graph, where this is the ASRS, this is the World Health Organization scale, and you see how these symptom scores are distributed with very high scores like, 16, 17, 18, almost certainly associated with a true and full ADHD diagnosis, and scores like 1 or 2 not, you see that there's no perfectly scientific threshold or cutoff. And so if you see someone, you're like, I'm not sure if I should conceptualize this as ADHD or not. I mean, it could be due to lack of training, but it happens to me every day, and this is all I do. We just have to understand that these problems are dimensional. And so it requires critical thought, and it also requires being humble. Like someone comes in, you're like, can't make an ADHD diagnosis today. Tell them they have some symptoms. Tell them that you're going to, if you really can't make the diagnosis, you're going to treat their anxiety and depression, and they should come back and you're going to reevaluate. because this is how it is in nature. This is how the diagnosis is. And so you can't be so definitive so quickly. Okay. The next two sections are brief, and then we'll have a lot of time for conversation. We're going to look at the concerns about mortality and morbidity with ADHD. So Russell Barkley is perhaps the most published ADHD expert in the last 50 years. And he had a brother with ADHD who died of a car accident at age 56. His brother drove fast, didn't wear a seatbelt, and Russell Barkley knew that his brother was at significant risk of early death because he's the one that wrote papers on morbidity and mortality associated with ADHD that got the most play. Despite knowing all of this and being like a world expert in ADHD, he was not able to prevent his brother's untimely death. And so it's really important to remember coming out. It's like one thing to remember. I mean, you have to remember two things. You have to remember the construct has a gender bias, and you have to remember that ADHD is associated with significant mortality. And so you have to think about that every time you're thinking about the diagnosis and you're thinking about a controlled substance and you're worried about the harms. Yes, be concerned about harms, and we'll talk about that. But you have to remember that untreated ADHD is really a serious condition. And then in terms of morbidity, basically any bad outcome you can think of, the research strongly supports that the risk of that bad outcome is somewhere between 50 and 300% more likely in a person with ADHD. So other mental disorders, substance use disorders, criminality, cardiovascular disease, being sexually assaulted, having motor vehicle accidents leading to ER visits, right? All of these are somewhere between 50 and 300% more likely, depending on the study of the population. So a highly morbid condition as well. Okay, and then we're going to talk about treatment. So in terms of cornerstones of treatment, different ways to break it down, but I like to think about these five. So a fundamental piece of psychoeducation, shame reduction, and grief processing. You don't need to be like a full-time psychotherapist to do this. If you identify an adult with ADHD who's lived a significant portion of their life underperforming relative to their other capacities, they're going to feel bad about the diagnosis having been missed. I mean, the field would just be so happy to get the diagnosis. They're just ready to roll. But some will say, like, I could have been a doctor. I could have done this. I could have done that. I could have, like, possibly stayed in my first marriage, right? Or even look back at really bad things that happened to them as kids and say, like, this might have been prevented if I weren't so impulsive. So it can be pretty hard. But if you sit with folks for 1 or 2 sessions, you work through with them, I'll allow them to be like, what do we do now? Like, how can I live the best life I can going forward? You just need them a little bit of time to deal with the shame and grief. And so then other pieces include behavioral interventions, managing comorbidities, family systems, as I mentioned. I try to make sure that anybody in the family, of anybody that I'm treating, someone's thought about ADHD in every family member, because the more family members you treat with ADHD, the better the family functions. And so it's nice to not miss people. And then we also think about medication. I'm going to zero in on the medication piece. Happy to talk about the other things as well. So in terms of stimulants, there's 2 chemical structures, methylphenidate base. So this is like Ritalin, Concerta, Focalin, and then amphetamine base like Adderall and Vyvanse. There's about a 70% response rate if one medicine's tried, about an 85% response rate if both are trialed. That would be, that could include people with comorbidities, but if someone has like severe major depressive disorder, you're not going to get that sort of response rate. You're going to have to treat the depression alongside treating the ADHD to get that sort of response. Effect sizes are huge. These are some of the most effective medicines we have in all of medicine, not just psychiatry. There aren't that many interventions that you have that give you an effect size of 1 in any field. The amphetamines are arguably a bit more effective and a bit more likely to cause side effects. So most of the guidelines say just start with one and then switch to the other. If there's a first-degree family member responds to a particular medicine, that's going to drive my decision. Someone's done great on immediate, well, here's an so let's say an extended release amphetamine product, and then their sister comes in. That's what I'm thinking about first. You need to think about time of the day. I'll flip over to the pharmacokinetic slides now. So a lot of medicines you prescribe, I mean, you just need to think like, do I have an adequate blood level? Is it, trough can't be too low, and for whatever purpose, you won't only give an antihypertensive that's metabolized in 2 hours and then give it again the next day, right? That wouldn't be sensible. And so you have to think about ADHD treatment in that way too. For most people, they're best off if you treat ADHD every hour that they're awake. But as you probably know, stimulants stimulate, right? So too much medicine too late in the day is going to cause sleep problems. It's not usually a problem in adults, but some adults have problematic appetite suppression. There are some other side effects we'll talk about too. And so you may not want kind of max effective doses every minute of the waking day, but you probably want to get as close as you can because ADHD is an inefficient condition to have, and the better it's treated, the more people can do with their days. People tend to like that, right? And so some commonly prescribed medicines you see here. So the graph on the left is dexmethylphenidate XR and then dexmethylphenidate IR. So this is Focalin XR and Focalin IR. And you see that although like it's not a disaster, both of these medicines are pretty peaky. And so the IR is a little bit peakier, but you could imagine that you give a certain dose and someone only does well when they're at 12 nanograms per milliliter, and they're going to cross that threshold within the first like 2 hours. But by hour 3.5, they're down below that level. And then it takes them another hour and a half after the second extended release section, the bolus is released, to get back up there, right? So Focalin XR could be a great medicine for some people, but for others, if you listen carefully and you ask the right questions, they're going to describe a hole in the middle of the day, like a 2-hour hole where they're not that productive. And those are an important 2 hours. They mean the difference between finishing your work, getting home, and making dinner for your kids on time, or always being late and feeling horrible about yourself because you're not managing basic household functions, right? And then the graph on the right is a relatively newer medicine, a prodrug, serum dexmethylphenidate and dexmethylphenidate combined versus this is now a higher dose of Focalin XR, dexmethylphenidate XR. And you see that the serum dexmethylphenidate, which is the black dots and the lower curve on the right-hand side, produces a much smoother pharmacokinetic curve. I mean, there's a huge difference. And so if you were prescribing someone 40 milligrams of dexmethylphenidate because you were trying to get adequate coverage out to hour 16, I'm sorry, the dexmethylphenidate XR, and they were like having tons of side effects, right? Maybe they only need to be above 5 nanograms per milliliter, and you do much better with this medicine that has a prodrug and has a much smoother release. So you really need to think about pharmacokinetics when you're thinking about stimulant medications. There's one more graph. It's busy, so I'll just point to 2 colors. I didn't find a way to get this less busy, but this is the demonstrates a number of different methylphenidate medications. And on the left, you see the concentration, and on the right, you see the first derivative of the concentration. So you see that the delayed release, extended release methylphenidate, which is an orange, and which is a medicine that's given at night, and then it absorbs primarily in the large intestine, so it doesn't kick in at all for the first 6 to 8 hours that you have it. You can see on the graph on the left in orange, so the blood level is 0, but then it starts to rise, and it looks like that curve is a little bit smoother, the orange curve, than the other ones. But then when you look at the first derivative, which gives you a sense of the rate of change in medicine over time, you see that that orange curve, though the graph is busier than I'd like, is pretty smooth. The rate of change going up and going down is not so substantial. And some of these other medicines are really peaky. And so side effects can be a function of blood level, but they can also be a function of rate of change of blood level with stimulants. And so again, you need to be thinking about pharmacokinetics. All of this is Googleable. I have some of it memorized. This is all I do every day, but I don't have all of it memorized. So you just type in Vyvanse pharmacokinetics, and you grab one of the first 5 graphs and you look at it, and it tells you what to expect from Vyvanse. Okay, so it's very easy to access this material. Briefly, non-stimulants. Atomoxetine is the one that's really highly evidence-based in adults, also known as Strattera. Pretty good effect sizes, still better than many of our interventions in medicine, but not where stimulants are. It can be slightly helpful for anxiety, but if someone has ADHD and anxiety, don't go for a 2-for-1. It's just not a good approach. If someone has mild ADHD, you don't want to prescribe a stimulant for some reason, you give them atomoxetine, maybe their anxiety will be a little bit lower. That would be lovely. right? But it's a failed depression and anxiety medicine, which turned out to work for ADHD, okay? And so you start to see some effect in 2 to 3 weeks. It can be titrated very quickly, from 40 milligrams, which is the starting dose, to 100 milligrams in like a week. Then you have to wait 2 to 3 weeks to see what it does. For adults, almost everybody does best on 100 milligrams, but certainly some people could be sensitive and benefit from a lower dose. Another medicine which is helpful, I'll mention guanfacine ER, an alpha agonist, and then also clonidine. These medicines are also helpful, but not very evidence-based in adults, unfortunately. But they're relatively cheap and they're usually pretty well tolerated. In kids, guanfacine ER in trials head-to-head looks about as good as a stimulant, but in adults, we just don't have research supporting that. They lower blood pressure and heart rate. They can reduce anxiety. They also can counteract stimulant hypertensive effects. They're particularly helpful if people have ADHD symptoms in the evening and are not on atomoxetine. And I often give them to adults who have great difficulty getting organized to get into bed or choose to not go to sleep in order to create a higher level of discomfort at the time that that adult should go to sleep to make them sleepy. Because the decisional balance between staying awake on a device where you're getting like immediate dopamine hits, reward, and feedback versus going to bed and getting sleep you need for your brain to function. I mean, all of us make this mistake sometimes, but ADHD adults make this mistake a lot more. They just stay up. And so if you give someone guanfacine, which is a little bit sedating, you can also give the IR form, or clonidine IR, which is even more sedating, and they take it an hour before bed. They're kind of uncomfortable by the time to go to sleep. So of course they have to be willing to participate in this process. But many people say there's nothing that I want more than to get more than 5 hours of sleep a night. I just can't figure out how. And so not only do these medicines treat ADHD, but they can also shift the decisional balance about getting sleep, which for many people with ADHD is really important. A couple of slides left. So probably generally aware of risks. So the risks of stimulant treatment are really low. We've known forever that there's a few point elevation in blood pressure and heart rate. Most of the studies out of Scandinavian countries where they have population level databases do not show any excess cardiac risk. And so my interpretation is that they save lives from a cardiac standpoint because people like take their other medicines more frequently, exercise more, get better sleep. And then also the blood pressure and heart rate elevations are like not good. And so there's a cardiac cost, and they basically balance each other out. So in a population level, you can't see any excess risk, nor do you see cardiac lives saved. And then there was one recent study that showed marginally increased risk, like small single-digit percentage increased risk in some cardiac problem. It wasn't mortality, but it was like cardiac disease. I think it was atrial cardiac disease. And so it's important to think that anytime you give something that increases heart rate and blood pressure, it may be bad for the patient, and that has to be balanced right against other things. But the point is, it's not so big, and y'all are even better than we are psychiatrists at tracking blood pressure and heart rate and knowing what to do. So you don't even have to refer the folks to somebody else. You just keep an eye on it. And if it's clinically indicated and they're really benefiting from medicine, you start a blood pressure medicine. So this is like absolutely not something to worry about. It's something to monitor. And then diversion and misuse is perhaps the trickiest thing. Dr. Burke cued me into the fact that y'all are the professionals who were told 15 years ago that pain is the fifth vital sign, and now a lot of people tragically are dying from opiates. So it's important to be sensitive to the fact that you sometimes have relatively short visits. You have to be experts at like everything in the world, which is pretty hard. And you don't want to cause harm. So you want to be thoughtful about Schedule II controlled substances, right? And so there is some risk of diversion and misuse. The literature supports the risk really peaking between the ages of 18 and 25, not being nearly as high in other age groups. And of all of the studies that show a connection between the prescription of stimulant medications to people with ADHD and substance use disorders, all of the good ones either show risk reduction or don't show a significant difference. And so you put that entire literature together, it's reasonable to conclude that there's a small risk reduction of substance use disorders if you prescribe a person with ADHD a stimulant medicine. Still, there are things that you can do to further reduce the risk of diversion and misuse. You should be carefully assessing for substance use disorders for all of your patients with some frequency. And you'd certainly be doing that if you were prescribing a stimulant. You're reviewing the available databases, as you should be, right? There's literature to support the idea that only 1/4 of patients who misuse stimulants do so in the absence of a pre-existing substance use disorder. Of course, you're not always going to hear the whole story, even if you're great at assessing substance use disorders. But most people already have a substance use disorder if they're going to go on to use a stimulant in a way that's not consistent with their best health. So screening is helpful. So next recommendation, right? Use long-acting agents with smooth pharmacokinetic profiles. So lisdexamfetamine is a prodrug. I'm shifting people off the medicine because no one can access it. I mean, it's an unmitigated disaster. We can talk about that if you have questions about it, but it's a problem. I deem most of my patients not to be at high risk of misuse, but I treat people who've had stimulants use disorders, who've used cocaine. I mean, I treat all those folks with stimulants if the risks of non-treatment or using a less effective drug are greater than the risks of treatment. So it's really a problem. You also have Astaris and Jornay, or the brand names. So the Astaris is the sear dexmethylphenidate prodrug that I mentioned earlier. And then Jornay is the medicine that kicks in the large intestine later on. The beads are nearly uncrushable. And so you prescribe these medicines and it's hard to misuse them. Not impossible, but it's hard. And so generally, if you have concerns about misuse, you prescribe long-acting agents, and ideally ones that if they're crushed and sorted or in any other sort of form, just don't produce a high. It's just not possible, right? The shortages make everything harder. Benefits of stimulant treatment, you reduce the risk of bad outcomes. And we should also be thinking from a well-being promotion standpoint about promoting well-being. People live happier lives when they're more capable of doing things that they intrinsically are able to do. Okay, so I'm going to pause there. Just took a little longer than I expected, but we still have time for conversation.